thankfully, pathogen safety was addressed. Extended half-life clotting products have entered the market, including those with human cell line. But I think most of us know that sort of it's a nice incremental improvement to what we're really interested in now, which are the non-factor therapies. And tonight we're going to talk a little bit about gene therapy and cellular therapy. So gene editing is really exciting and interesting, but it's nowhere near ready for prime time. So maybe when this meeting is done in 2 years, we'll be talking about gene editing. So there's lots of strategies. And ultimately, if you see this little man right here, you know, the goal is to improve the care of these patients with hemophilia A and hemophilia B. Ultimately, we're trying to form a clot, whether that's through emicizumab, which mimics factor VIII, whether that's through anti-tissue factor pathway inhibitors, which increases thrombin generation, whether that's through fituzarin, which knocks down antithrombin, thus allowing thrombin to be formed, or what we're going to talk about tonight, gene therapy, in which the target is either the liver cell or one of the stem cells, and to decide to take over and just produce factor VIII. Gene therapies had a relatively short timeline. Yes, it was considered in 1972, but really it wasn't until the 90s in which gene therapy started. Unfortunately, at Penn, there was a death, and that was Jesse Gelsinger, and I think it's really important that people know who he is. He had a rare disorder. There was some preclinical data that was not shared, and some issues specifically with adenovirus, which is not used anymore for gene therapy. He ultimately died of something called DIC. That stopped things appropriately, and things were put in place to protect patients. The first gene therapy trial for hemophilia B was in 2005, and then the one in hemophilia A was in 2015. The reason why is that factor VIII is much more difficult to package, and we'll show that in a minute. The important thing for hemophilia, it is not the first condition. It is the third condition that will receive approval for gene therapy if you don't count things like leukemia as well. But there's a rare eye condition and spinal muscular atrophy in which young children are getting gene therapy. So I think it's really important that it's not the hemophiliacs that are the canary in the gold mine this time. With gene therapy, there's a whole new language that we have to learn. This is part of the paper that has been submitted for review. And it's going to be really interesting because they did a lot of groups in which they asked patients how they wanted to understand this. And we'll talk about this because we're going to be using terms like vector, functional gene, liver-directed therapy. These are all terms that we really didn't use a few years ago. The ultimate future of gene therapy has gone from this sort of up and down factor infusion, which obviously replaces the problem that's there, extended half-life, which does improve some of it, but does have limitations. Some of our non-factor therapies, of which only one is FDA approved, hopefully fituzarin will enter the market at some point. And it's not really clear whether the tissue factor pathway inhibitor products are going to make it to the market without modifications. And then gene therapy is what we're really striving for. And we'll show you some results of some of the therapies that have been entered the market, or at least in clinical trial form. So first, let's go back to a science lesson. I know it's Friday night and some of you may have started drinking. I've already had a little bit to drink, so that's okay. DNA, most of your cells contain tiny structures. You remember these little X chromosomes, these little X-looking chromosomes. Most of us have 23 pairs unless you have something like Down syndrome or Turner syndrome. And those are tightly wound forms of DNA. And they actually look like this. If you look under an electron microscope, it looks like these little X's. This DNA is the cookbook for the recipes that we want to make. And it's really important, and it's a very complex recipe. So it's like a super complex one. This isn't like one you just throw in your Instapot. It's a complicated recipe. This one takes a lot of finesse in the right order, or things don't work out. When you talk about DNA, within that DNA, there's a segment, and that's called a gene, that has the very specific instructions for making the proteins. And in this case, it's the gene for factor VIII or for factor IX, and it makes those proteins. The proteins are complicated molecules. Sometimes they have to be controlled by multiple genes. In the case of hemophilia, it's controlled by one gene. But in the case of something like von Willebrand factor, clearance and production are controlled by more than one gene. Proteins are the essential building blocks. and they're important for producing proteins for what things that everybody cares about today on this call, which is factor VIII and factor IX. So what happens with hemophilia? Well, there's a mutated gene. They don't like to use the term mutation. It is what it is. A variant is another term, but that's not a term that was typically preferred by hemophilia patients. So the term mutation continues. There are different types. You can have one where you don't make the protein correctly, you don't make enough of the protein, or you make too much of it, which in the case it's going to be interesting. There's a mutation called the Padua mutation, which is being exploited for hemophilia. But in the case of the people on this phone call, most people don't make enough of the protein and thus have deficiencies. And some of you with a milder and moderate disease may just make a very dysfunctional mutation. All right, so let's talk about monogenic conditions. So that means a single gene, so monogene. And these are things like cystic fibrosis, hemophilia, Huntington's disease. These are perfect for gene therapy because there's a single mutation. Specifically, sometimes things like sickle cell is even better because it is everybody with sickle cell has the exact same mutation. And thus, sickle cell likely will have significant improvement in some of these cellular therapies before hemophilia because it's much easier to target because everybody has the same mutation. So it's really important that everybody knows the way that we study drugs and in this case, gene therapy. There are preclinical studies, so that means animal tests in which they ask basic questions of safety and whether something is even going to work. So it goes from a crazy idea to does it work in animals, in cell lines, and then it has to take the giant leap into the phase 1, phase 2, and phase 3. Phase 1 is small groups of patients. So for example, our cellular therapy trial that we have at Emory is going to be 7 total patients. The studies I'm talking about today, some of them only had 3 patients. And so if you enter a phase 1 trial, yes, you may get results, but you have to enter it understanding that you may get absolutely no benefit. And that's really important for people to understand. As you get into phase 2, they're looking at whether it works as well, not just the safety of it. And then phase 3, they have to get data to show that it's consistent, that it's efficacious, that it's safe in a large group of patients, and that will satisfy the FDA to allow approval. For example, Biomarin was able to show in 16 patients of their phase 3 and of their previous phase, they were able to satisfy the FDA approval and thus be able to move forward and get approval before their study is even done. All right, and then after this, it's really important. So for example, some of the studies that we're participating in, including the one at Emory, we're gonna follow those guys for 15 years. And that was actually important when it came to choosing a hemophilia provider. Hopefully I'll be working in 15 years. If gene therapy puts me out of business, so be it. I think that's great. But it's gonna be important that we follow these patients for a really long time. So those of you get gene therapy, you don't get to skip out on meetings. You still gotta come back to meetings and you still gotta follow up with your blood brothers and blood sisters. So there's 3 types of gene therapy that you need to know of. Gene editing, which we're not gonna talk a lot about today, which is the future and likely will be a reality in the next 20 years. There's cellular therapy. This is what's revolutionizing leukemia care in children and adults. What this is typically they take the stem cells out of the body, they infect them, and then they put them back into the body and hope that it will actually produce protein. So you introduce a functional gene typically in the stem cells. And then there's gene transfer, which is widely what's been done to this point. And you get more than 3 viruses. This is a little bit deceiving, but this is what we're talking about. When I say liver-directed in vivo therapy, that's what gene transfer is. All right, let me see here. So what are the goals of gene therapy? Well, we want to design a working gene. We want to be able to get that gene into your body. We want to make sure that whoever participates in the study actually meets eligibility, which we'll talk about. And then we want it to actually work in the body. It's not enough that it works in the animals or in the cell lines. It's got to work in the body and it's got to be safe. You have to monitor this very closely in this population. And there are going to be some of you that are going to be like those people that buy the first iPhone when it comes out and you stand in line and get it. And some of you say, well, I'll just wait a few years and see, wait for the second one. Maybe that Apple Watch, the one that goes underwater is better than the first one. And that's totally fine, but it's important that we all support each other in our quest to cure hemophilia. It's going to be really important when we talk about this, about the gene transfer, because this is the future of hemophilia. We're not going backwards, we're going forwards, and it's really exciting. Next 5 years is going to be quite exciting for this group. There are lots of different viruses, and sometimes they're scary because some of these viruses are in the same family of viruses that affect people like hepatitis and HIV. But these are very different, and we'll talk about that. The ones that are largely, the one that killed Jesse Gelsinger was adenovirus. This one was not a good target, but we've learned is adeno-associated virus is a better one because it doesn't cause an infection. It's quite useful. It's potentially long-lasting, and it has a very low level of integration. Although it says integrating here for the lentivirus, it actually hasn't been shown in practice that it is integrating, and potentially could have a very long-lasting effect, much longer than AAV. And so that's going to be really important because that may be the next step that we take after the liver-directed therapy. Or it may just be, it's going to be like a buffet. You get multiple options and you decide what you want. Do you want something that potentially is temporary, or one that may last multiple decades with slightly higher risks? Everybody's very different, and so that's really important. So the other terms that we like to use are viral shell or capsid, and this is actually what it looks like in adeno-associated virus. They've stripped out what makes this thing infectious, and this one doesn't actually cause an infection in humans. That's why it's called adeno-associated virus. It needs adenovirus to help. They strip out what's in there, so it's basically an empty shell, empty or neutralized virus, and then we bioengineer and we include something called the gene transfer cassette, or the vector. So now it's a therapeutic vector. So it goes from gene to viral shell. Now you got a vector. And most of you haven't used that term cassette for a long time, because I think I've thrown out most of my cassettes from my car. So I don't know if anybody's still got functioning tape players in their cars. And this is a nice visual. So we like to use sort of the analogy of the therapeutic vector, something being delivered. All of us know what delivering food, delivering through Amazon, or delivering whatever to your house. And so we have to find a way to get to the cell that we want to. And in the current state, adeno-associated virus is trying to deliver it to the liver cell. Initially, we attempted to deliver it to muscle cells. That didn't work. And the multiple attempts to deliver it to the liver didn't work. And it was only when Nathwani and his group was able to have success almost 10 years ago. So you have your vector. Remember, that's the shell plus the gene. It's injected into the human just like you inject anything else from a bag. It's injected slowly because you're injecting, trillion, just incredible amount of virus into the body. It has what's called a tropism, which means that it's trying to go to a specific tissue, and in this case, the liver. It ultimately gets endocytosed, and then it goes into the nucleus. Remember, that's the place where your DNA is held. It doesn't go into your actual genome. It actually forms a circular DNA that's called an episome or concatemer. And that's where the DNA is going to stay. And these cells over time do die. And so when that cell dies in the liver, so goes that circular DNA. You don't pass that on to your children. That stays with you and goes to the grave with you. And so this DNA is outside of the genome. There is concern in some of the studies that were done in dogs that there could be some integration, which is something we did know about. But so far, there's been no evidence that it's inserting anything or causing any kind of oncogenic effect, meaning causing cancer. Obviously, we're going to continue to follow that very closely. But your body will continue to make the abnormal protein or very little of it. And then in addition, you're going to make this functional protein in which you receive gene therapy. So this is the process in another visualization. So you got the delivery package, which is the adeno-associated virus or the lentivirus. In this case, it's transported into the body. Once it gets inside the cell, it opens it up just like opening up a package. It has to be delivered through something. That's through a needle. It goes into your bloodstream. It used to have to be injected directly, but now it goes through the bloodstream. It goes to the liver, which is the target in most of these gene therapies. The big thing that we're trying to do is that your immune system doesn't like to see quadrillions of viruses floating around in your body, and it can react to it. And that's what we're trying to work on. Can we make a capsid that will not make the body overreact? Because what we don't want to do is the immune system do what it does and create antibodies and neutralize all of it before it becomes effective. Immediately after gene therapy, within a few weeks, you have very strong antibodies against that. So if we tried to give you the same adeno-associated virus, it would not take, it would be immediately neutralized. So that's going to be an important issue moving forward, is how do we redose patients? Because that's going to be a struggle for the future. There's lots of considerations. A lot of people want to know, well, should I consider gene therapy? Well, right now, it's largely excluded female patients. It's going to be focused on males with hemophilia. When it comes to disease severity, it initially was only people less than 1%, but a couple of the studies have opened up and they're moderately severe, so even as high as 2%, assuming that those patients have a significant bleeding tendency. Additionally, patients with inhibitors have largely been excluded on this, but there is one case that we're going to talk about that Spark has. It's an exciting study that potentially could be useful. Right now hasn't entered that phase. And then the biggest problem is these neutralizing antibodies to the capsid. Remember that neutralized virus. We naturally have been exposed to these viruses, even though they're non-pathogenic. And then once you create these antibodies, just like if you got a vaccine, it's very hard to get past it. And if you have strong antibodies, you may not qualify for the study. And in some locations, up to 30% of the patients could be completely excluded from the study based on this. The only caveat is there's a few factor 9 studies that it doesn't seem to matter that they have these neutralizing antibodies. And we'll talk about that. Age is important. With every clinical trial, it always starts with the oldest patients, and then we go down to the youngest ones. So all gene therapy studies are 18 and older. One of the things that we have to talk about, and I think I worry about, we had a patient recently that went off to college and hurt himself trying to do a keg stand. Sometimes I think maybe those 18-year-olds are not going to be a good idea, because it's really hard to ask 18, 19, 20, and 21-year-olds to abstain for alcohol from 6 months. Some of people say, well, that's ridiculous, but I'm just telling you that's reality. We are worried about that because binge drinking potentially could have an effect on the transgene expression. Family planning is important. So usually barrier contraception has to be done for up to 6 months. So there can be no family planning for 6 months and potentially longer. We're waiting for FDA guidance. And then comorbidities. Some patients with HIV and hepatitis C have been excluded. There have been a few medications with HIV that have actually affected the ability to have good expression in the liver. And so we don't know what's going to happen with the FDA if they're going to put limitations. So that's something we're going to be looking forward. So there's tons of therapy studies that are entering phase 1. I wanted to focus on the phase 3 studies. This is Steve Pipe's paper. So let's talk about the one that's going to enter the market the first. That's Biomarin's. I'm not going to try to pronounce these ridiculous names, but you can see it there. And I think they like to call it Valrox for short. And Dr. Passy has been the one that's going to present the data. And you're going to see more data at the WFH and ISTH meetings. They haven't released a lot of this data, so we're waiting for that update. So Biomarin gene therapy is a phase 1. It's not a phase 1/2. It's a phase 1/phase 2. And when they did that, they had a lot of different cohorts, a lot of different doses. Initially had 15 patients in 4 different cohorts. They were looking for patients that largely had significant disease. They had significant target joints, and a significant number of them actually had hepatitis B or C. They didn't have active disease, and everyone except for one was on prophylaxis at the time. Cut to the chase. If you look here, you see the bars on the left. Those were the bleeding rate. And remember, we annualized the bleeding rate. So that's about how many bleeds per year if you follow somebody for 6 months and you estimate it. Most studies show about 16 to 30 bleeds per year. And then post that, you can see the numbers are really small. You can't even see the bars in some of these. And what you can see is that the bleeding rate is very low. The large proportion of the patients are bleed-free up to year 3, and there's a 96% reduction in bleed rates. As expected, because these patients have levels in a 10, 15, 20% range, they shouldn't be bleeding. And they should have very little bleeding. and they shouldn't have a lot of spontaneous bleeds. And as you can see here in the other cohort, they additionally had significant reduction in bleeds, and all of the patient had resolution of target joints, and all of them were able to get off their prophy. Here's another visualization of this. You can see early on, we actually were a little bit worried because the factor VIII levels got actually really high, as you can see here, well above 100. And there was actually a lot of concern that maybe that was actually too high. Thankfully, over time, it's settled out, and you can see here, one of the challenges with adeno-associated virus and hemophilia A is this trend. You see this nice peak in the first, 5 to 6 months, and then it starts to slowly go down every single year to where now you may have been at 100% early on, and now you're at 20%, by 3 or 4 years later. What worries us is that by year 7 to 10, you may have complete return. We don't know that. We'll see. It may completely plateau out. And then the other thing we have to look at is factor VIII is measured in 2 different ways. For the most point, I think we're going to be following the chromogenic assay, which is a reasonable assay. But again, we're going to follow bleeds on these patients. This is another visualization of the interim analysis. It gives us an idea of what it's likely going to look like. And I think it's important to see that this is the goal. Initially, we were shooting for 5, 10%, but obviously we may be able to get even higher, which is essentially a temporary cure at levels above 50%, which is obviously very exciting. They have to take this from a research production and then take it to full scale, which in itself is a very difficult task as well. All right. So year 3 and 4 update came via email. They like to get this out to the shareholders. A lot of these companies got yelled at last year when they gave too much results because they're not supposed to release large results before an actual meeting. But here it is. 15 subjects remain off factor VIII prophylaxis. The vast majority have had no spontaneous bleeds. You can see the ABR rates here are very, very low. And the actual factor VIII levels hopefully will be released next week. And there's something called, in mid-August, we expect the FDA to approve it. We have, absolutely no idea how the pay structure is going to be. We don't know how long the insurance is going to take to review it. I can tell you it's going to be a long time. They're not going to just approve products that are this expensive with a large upfront cost unless there's a significant change. But I can tell you for those that have received it for the retinal dystrophy and for the spinal muscular atrophy, the insurance companies have paid out for it immediately. And so we may be flailing our arms around realizing that the companies are just going to pay for it and it's not going to be a big deal. So that's Biomarin. That has the most data because it's the closest one to there. The next one is Spark, and there's some discussion because Spark has some products, which you'll see at the end, which is a collaboration or purchase by Pfizer. And Spark has recently joined the Roche family. So as you know, you see lots of people's clothing change and the colors change. Companies change names like crazy now. So this is a Spark data. This is a bioengineered AAV, and I think it's a little bit closer to the AAV8. It is a specific capsid called the Spark capsid. And you can see here, stable factor VIII levels have been seen in the majority of patients. We don't have a ton of them. One of the issues is that steroid was required in a good portion of these patients, and 2 of them actually lost response. One of the issues that we need to deal with is that when you participate in these studies, as soon as we see even a small rise in your liver enzymes, we have to immediately start steroids. And even then, it may be possible that you lose expression and not able to recover that. And some patients, for some of these trials, have had to be on steroids for months and months and months. We haven't seen any negative effects of this, but clearly anybody knows if you take steroids for a few months, you may have some negative effects. We expect to see data for an ISTH. That's what we're expecting to see. So hopefully we'll virtually see this, but you can see the same results for the Spark. You see the bleeding rates are outrageous before, and they're reduced to near nothing afterwards. Significant reduction in factor VIII consumption, and the majority of patients are able to come off factor VIII prophylaxis. And so good results from this. One of the things that we were hoping for is that we would see the phase 3 start this year. but after some discussion, they've decided to optimize some things, and likely phase 3 will start sometime next year. We don't know for sure. And so in the Spark study, again, I'm going to use their name instead of using this. One of the most interesting things is there's going to be 2 parts of a study in which they may be able to offer gene therapy to those with inhibitors, which is really exciting. But right now, they're only starting with part 1, which is non-inhibitor patients, and they have to be able to demonstrate that this works in that population, which is a much easier target than obviously the inhibitor patients. Here is the inclusion criteria. I put it up here because it does have some loosening of the criteria in which some patients could get it with levels as high as 2%. You have to be lots of exposures. You can't have active HIV. You have to have a good CD4 count, and you can't have active hepatitis B or C or have significant liver disease. So that's really exciting. Hopefully some of you will consider participating in that study. So let's move over to hemophilia B. Actually, I think hemophilia B actually has had the best results. I know the hemophilia A gene therapy people maybe on this trial may be cringing a little bit, but I don't think anybody can deny the results. And I think when you see some of the other results upcoming in the trials, you're going to be pretty wowed. We talked about mutations in which you produce too much factor IX, and one of them is called the Padua mutation. And there's a group of family members that have really high factor IX levels, really potent factor IX. And so somebody thought, well, how about we put that mutation into the gene therapy? We put that into the cassette, and we can get actually even better expression in those that have severe Hem B. And so that was the idea, and it seemed to have worked great. So this is what it looks like, the AAV5. It has the Padua variant. There were 3 participants to start it out. They had to meet criteria. If the criteria were met, then they were able to go on from the AMT 60 to the 61. Those 3 patients did really well. As you can see here, we had patients with levels of 30, 40, and 50%. The mean level at 52 weeks was 41%. That's just remarkable. So think about that. 52 weeks later, we have patients with levels in the near normal range. And so that's just really quite exciting. And thus it met criteria, and it was able to move forward. There are 56 patients enrolled in this study. This study opened and closed super fast. It was called the Hope B study. The most interesting thing is they did not exclude patients no matter what their antibody titer was, which was really exciting because that was a huge limitation for other studies. And so far, the data hasn't shown that those that had existing antibodies did worse. There actually doesn't seem to be any connection to that. And so it's really exciting that they may be able to overcome this, at least in the hemophilia B. And the data looks quite exciting for these patients for the future. So that was the Unicure study. That was presented by Von Dragowski. Most of these don't have papers published on it. They only have meetings. And hopefully we'll see some of this next week and the few weeks afterwards. Not even going to try to pronounce this next one. It's got a ridiculous name by Pfizer. But this one is through a partnership with Spark. And very limited data online on this, but I was able to find some through medical Twitter. And you can see here, I guess this was an investor communication that I somehow got a hold of. You can see here the results are quite remarkable, in which some patients were able to achieve factor IX in the non-hemophilia range. So again, Spark Capsid, which is a modified AAV8, and it also has a single strand factor IX with the Padua variant included. And you can see there, even these patients are obviously not, I'm sure, not upset that their levels are in the 30, 40%. And it seems to level off. And if you look back at the original studies, a lot of those studies actually showed patients in which they still have expression 7, 8 years later. So there seems to be something with factor IX when you put it in the liver seems to be okay with it. It doesn't sort of freak out. It doesn't stress the body. Where factor VIII seems to stress the machinery of the cells. Obviously, we're going to have to work on that and figure out how we can make that more acceptable in the hemophilia A patients. And so again, here you can see the data looks really, really exciting. the durability of these, and it looks pretty stable, like it's not having significant drops. When you see levels of 40 and 50%, that's about the same when you measure them in these assays. So very, very exciting. And this is just pretty remarkable too. You have patients with almost 100% level, which is just amazing. Who would have thought we would see something like that? All right, that's the in vivo study. We're rounding out the last couple of slides. These are the ex vivo gene therapy studies. So these do come with some increased risk. One of the more exciting studies that's happening is happening in Wisconsin, and one is happening in Atlanta. What this requires is sort of like a hybrid of a stem cell transplant and gene therapy. And hemophilia didn't create this idea. This is already happening in thalassemia and sickle cell. So hemophilia is actually later to the game for this. But we think it's still important. And there's some people that say that, I'll be curious what people think, that this is too risky to take for our blood brothers to consider this. But I think this is where everybody makes a decision for themselves, because the potential reward could be lifelong production of factor VIII in the normal levels. What this one is that what they decided is that they want to make factor VIII in one of the stem cells here, as you can see in this little thing that looks like an egg. One of the cells that's important in your body is something called megakaryocytes. They thought that if they can put it in the granules of your platelets, which are actually don't have any cells, they're actually acellular pieces of a cell. And since platelets go to the same site of damage, they could open up, dump their granules, including the factor VIII, and potentially the factor VIII could be dumped at the site and evade those inhibitors. So this may actually be useful in inhibitor patients. But this is a phase 1 study being done in Wisconsin. It's using the lentivirus, and you can see the cassette here, now that everybody knows what a cassette is. And what it requires is that you have to have a catheter placed. You have to give something to stimulate your stem cells to come out, just like if you did it for stimulating your ovaries to produce your eggs, and those that have ever harvested those. It does require small amounts of chemotherapy. And the amount of chemotherapy is really important. So it's not the fact that you have to get this, it's the fact that it's very reduced. And so it's reduced to the point where it's just enough to allow your body to accept these stem cells. So you harvest the stem cells, you give the medicine, in this case it's melphalan and fludarabine, and then you introduce that, you actually transfect the stem cells with this virus, you check to make sure it went in, and then you re-inject it into the body, just like an infusion. There's a temporary amount of time for the next few weeks in which your platelet count and your red cell count and your white count will be down, and then eventually you'll engraft. The dose that people are giving you is enough to the fact that if you left and disappeared after you got this, you will eventually engraft afterwards. And so that was really important. And this could be really helpful for our patients with inhibitors in the future. So this study is just now opening in Wisconsin. I don't know if they enrolled any patients. We've talked to them recently and they're really excited, and we're excited for them. So one of the studies that I'm involved in, just for full disclosure, but this is Dr. Trent Spencer's, Chris Doring, and Pete Lawler's study. And this is their slide. It's a similar concept. It's ex vivo gene therapy. And in this case, we're using a very reduced dose of busulfan and ATG. And so there'll be an outpatient visit. We'll harvest those stem cells, isolate the stem cells, modify them with this lentivirus. And the goal of the lentivirus, which has this cassette in here, and they tried to make a very optimized version of factor VIII. So they're trying to make a factor VIII that's super highly expressed. And the goal is that your cell lines, your myeloid cell lines, will start producing factor VIII from your bone marrow. And so it's the same idea as the Wisconsin. They decided to put it in platelets. We're deciding to put it in myeloid cells. This study is about to be IRB approved. It's got approval from the government to move forward. In about 3 months, we're going to have our first guy that participates in this study. We want 7 men to participate in this study. We're all very, very hopeful that this will be the next wave of gene therapy after the in vivo gene therapy. So the last few slides, measuring success. We obviously have lots of things that are important, short-term, long-term, and obviously we don't want anything that causes death. Some people say that gene therapy is too risky. There have actually been people that have died from their own therapy that they're currently getting. There are people that are still getting life-threatening bleeding events. So I still think that hemophilia is a life-threatening disorder. I don't think anybody on this doesn't think that. And so, so I think, you know, I think it's worthwhile to consider these therapies that do come with inherent risks. Obviously, we don't want any significant integration in the host genome because that could be something that leads to cancer down the line. We haven't seen any of that from the gene therapy studies from 8 years ago, and none of that in the dog models. We didn't see any transformation to any kind of liver sarcomas. It's going to be really important that we don't cause any liver problems, that we don't cause inhibitors, and of course, we don't want to have an overreactive immune response. In addition to those hard outcomes, we want these softer outcomes as well. We want to control pain, we want to make factor, we want to have sustained factor, and we want people to feel like they have been cured of their hemophilia, which I think is really important. I've talked to people like Glenn Pierce, who say they just feel different now that they don't have hemophilia. And so, you know, I think it's a different feeling. That's something I'm never going to understand, no matter how many people tell me. And so I think it's important that we factor in those quality of life outcomes. So the last few slides, I think in hemophilia, we talk about lots of different options. We talk about, you know, choice. It's really important that hemophilia it's like a humongous buffet line at one of the South Carolina meetings, right? And you get a huge choice, right? You have your substitution and hemostatic rebalancing therapies. That's going to be great for a lot of people just because that's really good for a lot of patients. We have some patients that are not willing to take any other additional risk and jump into the new therapies. That's fine. Also on that buffet line, there's other things that may be available, like things like emicizumab, fituzarin, hopefully an anti-TFPI drug will be there. We have to think about those thrombotic risks. They were there already. You already have friends that have had blood clots from current therapies. So it's not like this is a new problem. It's just being tracked very closely. We obviously have to worry about the peak bleeding risk events that people are controlled from that. And then the future holds a lot for gene therapy. So it's just like the basketball programs, one and done, right? I mean, AAV probably isn't going to be one and done. It may be like 3 or 4 and done. But that's okay as well. You get steady state hemostasis. We have to think about the cost because we can't bankrupt our healthcare systems. And we want to make sure that this is available for as many patients as possible. This is going on. Some of the studies that we're doing in Atlanta are actually ongoing in India right now. So this isn't just something that's happening in the United States. For gene therapy, it's just, there's a lot of people that just aren't going to be available. They're not going to be interested. They may have antibodies, they may have inhibitors, or they may have high risk with HIV and hepatitis C. And so it may not be useful now, but it potentially could be useful in the future. And so hopefully the future is coming. We'll all be flying high there, and hopefully you guys will join us in the future. And thank you very much for allowing me to come tonight and speak at your meeting. Maybe next year I'll be there in person, and I'm happy to take any questions either you know, through the chat or otherwise, and I can read those. So thank you very much.
Thanks, Dr. Sidonio. We did just have one question come through this chat.
Okay.
When we see our hematologist and labs are drawn, are these viruses that you spoke of towards the beginning of your slides routinely screened for, or is this something special that we do have to request?
That's a great question. So nobody routinely checks these. This is a highly specialized lab. And so, like, for example, some of the studies are using adeno-associated virus 5, adeno-associated virus 8. They're bioengineering, so it's a version of it. And so we don't know how many people already have those pre-existing antibodies. We have an idea based on our population in the United States, and so the companies have shifted to using the viruses that aren't highly prevalent in the United States. But if you look at some of these viruses, like in Russia, you know, 60–70% of the population may have that. So that's going to be really important. So we're not checking for those because remember, they're non-pathogenic viruses. When you send things to the CDC, we're keeping track of important things like Ebola, hepatitis, HIV, and we've actually asked them to look at COVID-19 or SARS-CoV-2 to see how many of our community members have been affected by this, because you may have gotten it asymptomatically. But when you participate in the study, they will test to see if you have any of those neutralizing antibodies. So great question.
Thanks, Dr. Sidonio. A lot have rolled in since then. Let me try to scroll to the top.
Sure.
What are some of the psychological prep steps you'd recommend for people seriously considering gene therapy once approved?
That's a great question. So some of the people have brought up the idea of whether, having a social worker and a psychologist meet the family to make sure that they're in a good state, that they feel, and I think that's important. We actually do that, and that will happen for the ex vivo gene therapy, because that is a lot that you're going to take on. When they actually meet these teams, there actually is an assessment to make sure that you're in the right psychological state of mind, because this is something we don't want somebody to bail out right before they do it. And so that's important. They're not doing that routinely, but some centers can have their psychologists consider talking to patients. And I think at our center, at least, anytime somebody wants to see one at our center, we have one available. We actually do distress screening when we see our patients, and so that meets certain criteria. But I think that's a good idea. Hopefully those people on here listening, the gene therapy companies, I think that's a great idea to think about that. So yeah, great question. So I can see some of these questions on here, Carrie. So how can someone who wants more information about the one in Atlanta? Yeah, well, you can email me, that's fine. I think somebody can provide you the email. If you go on clinicaltrials.gov, there is contact information, and please do tell them that you heard it from me. I think it's helpful. You don't get any discount or anything, but just, it's not like, but it's nice that people want to know where people have heard this, because I think it's important. I'm excited for the one in Milwaukee. I want both of the studies to work. I want all these studies to work out. I want multiple gene products available on the market. I don't want one company controlling the entire gene therapy market. I don't think anybody wants that, except for maybe that one company. But I think that's important that we have a variety, because I think that competition is important for our community. Carrie, it looks like the next one, and catch me if I miss one. Can you talk about the characteristics that you see with people that have strong antibody responses? So there isn't anything special about you if you're one of these people that has antibodies. That just means you got exposed somewhere down the line. You would have had no symptoms of it. So it's just one of those things. Some of these people have 30% of the people have antibodies, pre-existing antibodies, and your immune system may have made stronger antibodies because they got a good load of it, or they didn't. And so it's just the luck of the draw. Unfortunately, there's nothing particularly different about patients that have antibodies. The most exciting thing, like we talked about in this factor IX studies, is it hasn't mattered as much whether they had antibodies, which is so exciting. So less people were disqualified from the Unicure study, and that study filled up super fast. And so that was really exciting to see. Go ahead.
There was one up at the top here that says,
okay.
what are companies doing to educate insurance companies of the benefit to buy into the cost?
Yeah, so they have constant discussions with them. A lot of them are going to be having lots of discussions. There's things like a group called ICER. When emicizumab came out, what they wanted to do, and when any new drug hits the market, so for example, a new allergy drug comes to the market and it's a prescription, the drug companies want to look at it and say, is this any better than the other ones? Is Allegra better than Claritin? If it's just slightly better, but it costs 3 times as much, we're not going to push that. That's what they do in other countries. They just say, we're not doing that. If it's a little bit more expensive, but a lot better, then yes. And there's a certain threshold that these drugs have to meet. And so there is a group called the ICER group that looks at these kind of things. They analyze the cost and they determine, is this cost reasonable for the amount of time you expect to see it? They've already had discussions with drug companies, whether it'll be like a mortgage. So if you buy a house for 10 years, a mortgage, and you pay out over 10 years, the US healthcare system's a little bit unique because you might be on Blue Cross one year You might go to United next year. And what happens is Blue Cross doesn't want to pay for your care for the next 10 years. Whether everybody likes it or not, they don't want to do that. And so that's, they're having ongoing discussions. We're hoping that some of this has already been discussed with the insurance companies. And so until the first one hits the market, we just don't know what's going to happen. So Carrie, you might have to catch me up on the next questions here.
I got you.
Right.
How will gene therapy work if you have other diseases such as sickle cell?
Yeah, that's going to be challenging, obviously. You know, some patients, they have significant other hematologic disorders, and obviously sickle cell as a disorder, not as a trait, is a very significant disorder. And so right now, most of the studies would disqualify the patient. I think what's going to happen is in the future, that might happen is once it's available, I don't think those patients will be excluded. And so those patients with multiple disorders may have to wait until it's FDA approved, and actually may be some benefit to getting that taken care of so the patient can focus on their sickle cell disease. So, you know, obviously a tough, a double whammy there. So, but there's some exciting sickle cell therapies coming out. So thankfully, you know, those patients I take care of have a decent future as well, because it was pretty stagnant for a while when it comes to new drugs.
What is the expected duration to stay above 40%?
Yeah, it's different. So for hemophilia, ICER, so sorry. The expected duration is unknown. They think the early factor VIII gene therapies may last somewhere between 7 to 10 years. It potentially could last longer. We just don't have the data to demonstrate that. In some patients, most of the patients are going to be below 40% within a few years. And we're going to find out next week. So stay tuned for WFH. You'll probably see an email blast. You can just Google it too. Once it's presented, then the drug reps and the MSLs can start talking about the results. So for hemophilia B, it looks like 40% may last quite a while. And it may be that hemophilia B patients have some measurable factor levels for decades, which is really exciting. For hemophilia A, it's not clear if that's going to last more than 10 years. And so that's going to be tough. But again, you know, those patients on the first hemophilia B therapies have levels of 1 or 2% 8 years later. And the vast majority of them are not on prophylaxis and doing really well. So that's, you know, I know we want to keep moving the bar up, but, you know, we have to walk before we can run, right? So.
Absolutely. If a participant receives the first viral gene therapy and we see a decrease in efficiency, would a patient be able to participate in an additional gene therapy?
Yeah, as a clinical trial, that's unlikely that's going to happen. That's typically going to disqualify you because there's a lot of similarities between the adeno-associated virus amongst the different companies. I personally think in the future what's going to happen is we're going to have genetic defects. They're going to have these sort of ready to go, and they're going to be just inserting these genes to correct the problem in the future. I really think that's only about 30 years away, to be honest. But I think if you participated in one, you're highly likely to have cross-reacting antibodies. So if you did one that's AAV5, you're likely to have antibodies against AAV8. It's not 100%, but most of the companies as a trial will exclude you. It doesn't mean that you won't be able to get it as a product, but you definitely as a trial, that's highly likely because they're really trying to prove in the patient like that has never received it, so they can demonstrate that to the government that this is a working product.
Thank you. When on gene therapy and you have a bleed, do you treat the bleed with factor, and does it matter what product is used, or would you have to reduce the amount of units to treat?
Yeah, so the way we've been doing this is the factor is pretty steady. So it's unlike some of the mild patients. So you may have some mild patients on this call that have a level of 20%. If they run for 15 minutes, their level may go up to 40% for a few hours and then drop again. You don't get that response with gene therapy. It's pretty steady. You know, when you have a bleed, it may dip a little bit and then come back up. So, you know, we just treat the patient like they have that level. So if I have somebody that was less than 1% and all of a sudden they're 10%, I just treat them like I treat a congenital patient with 10%. Doesn't really matter what factor product they use. It's pretty irrelevant. And of course, somebody has 20% is going to get less factor than somebody that has less than 1%. And so it's pretty simple math. Our target is 100 typically. And so we just reduce the amount slightly of factor that we want to get, because what we don't want to do is give a blood clot. And I see the next question on here: in an emergency and trauma, all these patients have factor VIII in their house. One of the things, I saw one of these patients at a meeting and he said he didn't travel with his factor VIII, which really, really irked me. They still have to travel with factor VIII, because if you have less than 1% and you're 20%, that's no different than that mild patient traveling without therapy. You still got to travel. You still got to treat bleeds. If you have a surgery, you still got to treat. None of that changes. And so that's really, really important. And so that's, never leave home out without it, right? So I think that was an old commercial, right? It's a Discover card, I think, maybe. So,
yep.
Or is that the Diners Club? I don't know, one of those things.
Yes, I think it was the Discover commercial.
Yeah. Okay. All right.
Will the outcome be different if you have mild hemophilia?
Yeah. So none of the studies are approved or enrolling patients with mild hemophilia. And so it probably would be not effective early on with mild hemophilia. I think what we're going to see is our severe patients and our moderate patients are going to be first at the buffet line here, and our mild patients are going to be sitting at the table like at a wedding, waiting to be called up. And so I think it's gonna take some time, but first we have to demonstrate in our most severe patients that this works, that it's safe. Because our mild patients do have some factor, they do have ability to get factor products. And so, it's going to be a little while before we see our mild patients involved in these studies. That's not my rule. That's the FDA rule. That's the government rule. And the companies don't really have a role in this. So.
Thank you. This is kind of a combined question. We had a question about insurance. Has it covered gene therapy as of yet? And if you wouldn't mind spelling out the ICER question.
Yeah, ICER is, it's ICER. It's an incremental effectiveness ratio. And so it's a group called ICER, ICER. And then you can see that they've had a discussion about emicizumab. And so they are likely going to be talking about Biomarin's product at some point. And so we'll see what they say. They'll get a lot of input from physicians and provide information. And what was the other question again? Sorry.
It was a question about insurance coverage, and if you've heard of any cases of insurance covering gene therapy as of yet or not.
Yeah, I mean, I think it's unlikely that insurance is not going to cover it. It's covered spinal muscular atrophy for children with that. And remember, these are 2-year-olds that are getting 1 and 2-year-olds that are getting this gene therapy product. And they're, and if I remember correctly, it's injected directly into the spinal cord because they're trying to target that area. And the other people with the retinal dystrophy are also getting it as well. And the insurance companies have paid for them right out. They didn't do any mortgage thing. And so I don't see why it wouldn't get paid. I think there obviously are going to be restrictions in who gets it. They're going to probably want the neediest patients, of course, to be able to get this. And then the patients that are doing really well may be the last to that buffet line. So we're all hopeful that there'll still be some good food at that buffet line for those patients. So I'm going to keep with this buffet analogy. So
I think it's very relatable.
I think I'm just hungry. I think that's all it is. So.
And can you clarify for me really quickly? So on the mild patients, obviously they're going to go through the most severe first, but the milds, let's just pretend in a great world everything worked or whatever, they would still be worthy or qualifying of it. It would still work for them. It's not that they have to be severe or moderate to be able to have it work. Is that correct?
Well, so we don't know about that. And so remember, the mild patients may make some dysfunctional protein that may interfere with normal factor VIII. Probably isn't a huge problem. And there may be a part where you're making the factor 8 or 9, and then, this episome, that circular DNA is making it, and that may lead to a combined production of factor VIII. And so
that makes sense.
we don't know that yet at all. And it's going to be a while before the mild patients are going to be looking, they're going to be looking at that. One, because the government doesn't feel that group, that there's enough, they feel like this is too much risk for that group who has a much milder reduction, but it doesn't mean it won't happen in the future. It's going to be a few years.
That makes sense. Do we have anybody have any other questions they want to ask directly? Unmute yourself or anything.
Yeah, Sue.
Yes.
Yes, well, I guess it's directed to him as
yes.
Basically is how do you get on the program to, like be on the list to, like if Brett wants to try this, how does he go about, applying?
So it's a great question. The first place to go is the clinicaltrials.gov. And the other thing is you can just call your hemophilia treatment center and ask them what studies have you opened or what studies are you opening. And remember, we're taking patients from outside the Georgia area. Other groups are doing the same. And so, these are relatively small studies. Some of the first gene therapy patients were from out west that flew all the way down to Memphis to get gene therapy. And so that can happen, particularly for the companies. Oftentimes they will have some ability to pay for travel expenses. Obviously, everything got really nuts with COVID. And so anybody expecting to participate is going to be tested for COVID for sure, because that's something that's really of concern. Mm-hmm. I do know of some patients that have been affected that have gotten gene therapy, and so far it hasn't had an effect on it. So that's really, really good to hear. But, you may, if you're living in one state, you may have to go to another state to participate in the study, and your HCC is not going to be upset by this. But obviously, you should reach out to them and get advice, whether you feel like they're a good candidate. And you'll have to go through a screening process to go through the list. And the biggest one is going to be, whether you have a neutralizing antibody or not. So, so clinicaltrials.gov is supposed to be kept up to date. And then oftentimes, I believe, Sue, that HFA is trying to keep some of these lists as well, but it may not have the exact center that's available. So.
Yeah, and you can always call us and we'll point you in the right directions as well.
Okay.
We'll reach out and get that done. But
thank you.
Yeah.
Very good. Anybody else? Well, will you just do me one favor and come back next year to our hello, and we'll see where we are a year from now and present the next, a year's data of where we are and what's been happening in your center. We'd really appreciate that. That was an awesome program. Thank you.
Yeah, it's the first one I've done this presentation, so hopefully everybody liked it. And so, I'm excited. So I'm excited for this, and you guys, I'm hoping this will put me out of business and I'll retire happy. So.
Wonderful. You, Dr. Sidonio. Can I just say a quick plug and give a shout out to all of our funders here at HFA. We could not have presentations
there they are.
like this, as wonderful as this, without the partnership, especially from Takeda, Biomarin, and CVS Health for this particular presentation.
Definitely. I put the slides up there. Definitely, it's really important to do this programming. So thank you very much. Thank
you, Dr. Sidonio, for a wonderful presentation and for sticking with us tonight. Yeah. Enjoy the rest of the meeting. This was great. Yes, thank you.
Thank you.
Thanks,
and I have recorded this session.